wherever you're from. So my name is Needa. I'm a research assistant from the Institute of Healthier Living in Abu Dhabi. And I'm assuming most of you have not heard of us before. We're essentially a healthcare startup, and we are focused on personalized precision lifestyle medicine. And we're currently in the process of developing a clinical arm and a research arm. Now, one of the main things that we want to do is basically help lower the current chronic illness disease burden in the UAE, especially when it comes to like lifestyle-based diseases such as like obesity, diabetes, cardiovascular diseases, which are quite rampant in this region. Now, what we're doing is basically working towards getting a better understanding of the risk factors and the root causes of diseases in this region. And we want to contribute to research in this field. And at the same time, we want to utilize the latest evidence in creating highly individualized lifestyle intervention plans to resolve these issues and at the same time contribute towards healthy longevity. Now, we've got an excellent scientific advisory on board with experts from around the world, including Dr. Andrea Meyer, and they're helping us guide to basically create a difference in the healthcare landscape in the UAE and then essentially shift from sick care to promoting healthy illness-free years and resolve the chronic disease epidemic in this country. So as Dr. Eva basically mentioned very briefly, so today we are basically presenting results from an immersion program study and then kind of going into a deeper dive into one of the experiences of the participant as a case study. So I'll start with a pre-recorded introduction by our CEO, Dr. Nicole Sirotin, who's currently on a flight and could not join us, and then followed by our research lead, Dr. Bart, who will guide us to the rest of the program. So I'll just get started. So please let me know if you guys can't hear or see my screen. Can everyone see my screen?
Yeah.
Okay, awesome.
Hello, everyone. Good morning, good evening, wherever you are. My name is Nicole Sirotin, and I'm very delighted to be co-presenting this case study with my colleagues, Dr. Bart and Needa from the Institute for Healthy Living Abu Dhabi. I will let them introduce themselves. I'm sorry I can't be there in real time. I am an internal medicine physician by training and part of the original group of physicians certified in lifestyle medicine in 2017. I'm very passionate about the way in which we can bring lifestyle and the guidelines into actual clinical care for both prevention, but also for treatment of chronic disease. I have been a department chair for the last 10 years at Cleveland Clinic Abu Dhabi, where I built multiple programs, including a lifestyle medicine program in our oncology center, which is up and running and sees all of our patients that come in with cancer. And before that was part of a academic medicine career that spans Cornell and Albert Einstein and UCSD and UCSF. So I'm delighted to talk you through this case. It's a little different, I think, than most cases, and I really hope you enjoy it and the discussion is fruitful. So this started in 2021 when I got an email from the American College of Lifestyle Medicine asking if there were lifestyle medicine physicians in Abu Dhabi that would be interested in participating in this. At that time, I think there were maybe 3 of us, all working at CCAD. And the question was around participating in a health immersion project as part of a reality TV show. So not something I'm sure you were all anticipating with this case discussion. So there were 12 unhealthy Americans that were told, we want you to be part of a reality TV show. It's a health show, and that's all they knew. So they knew they would get medical testing, and they knew it would be somewhere outside of the US, and that was it. And so they were flown to Abu Dhabi, not knowing where they were going to end up or what was going to happen to them. They ended up getting their pre and post testing at CCAD. So putting my opportunity hat on, I said, let's make this an IRB approved study. Let's put in a proteomics assay, and let's really see what this health intervention does to their metrics. And so the data that my colleagues will show you are data from this intervention. I want to say a few things about the intervention very quickly. Number one, this was an intervention that was designed by an outside group. So I had no role, and neither did my colleagues, on actually designing the intervention or influencing it. We were really there to do the pre and post testing. This intervention is a whole food plant-based diet. And it includes some exercise and education around health, nutrition, many things that the team will go through briefly. But I think for the purposes of our discussion, I would say that the intervention itself is less interesting in the sense that, not less interesting, that's not the right word, but it is a, all of our discussions around nutrition and what is the best diet and how is it sustainable, and all of those real world questions, which I think are very important, are not as relevant in some ways as us just discussing this kind of intensive intervention and then really seeing the health outcomes that we showed, in my opinion. And so the proteomics assay that we did, we partnered with the company SomaLogic to do their Soma signal. And they were delighted to be a part of this research project and donated those tests for the purpose of this study. And then we went through a series of markers, which the team will go through, and really did it pre-post after the 3-week intervention. And I have to say the results were pretty remarkable. So some of you are going to ask, what happened to the reality TV show? It's still in post-processing, and it is hopefully will come out, and we will share it with everyone when it does come out. But our focus today is really on the scientific part. We have the overall data that we'll show you, in addition to one patient in particular that we'll go a little bit more in depth on. So I really hope that there's a fruitful discussion. And again, I'm sorry I can't be there in real time. I'm currently on an airplane, and happy to watch the recording and see all the discussion afterwards. Thank you all so much for your participation. Looking forward to the discussion.
Okay. And then now I'll have Dr. Bart take the lead. Thank you.
Yes, thanks so much. Thank you, Needa, for this introduction, and thanks to Dr. Sirotin for her introduction as well. So I'm Dr. Bart. I'm a neurologist and a functional and lifestyle medicine practitioner. How I get connected to this particular project was with my previous hat when I was a research director at Cleveland Clinic Abu Dhabi. And yes, I was one of the co-investigators in that. And currently, my role is I'm a head of research at Institute of Healthy Living Abu Dhabi. I'm based in Sydney, so bear with me because it's in the middle of the night. And it's raining. I don't know how the weather is at your side. So let me just share my screen, and I go with the with my presentation. I hope it goes smooth. Yeah. Okay. Let me just see what's happening here. Okay. Needa, can I ask you to maybe share screen from your end, because it's not allowing me to do that for whatever reason. Sorry about the technicalities. I just updated my system. Let me see. Oh, it's working. Sorry. Okay, it's working.
Now it's working.
Yes. All right. So let me just go to the full presentation mode. All right. Can you see my screen? Yeah. Okay. So this is Abu Dhabi Health Immersion project. We included 12 subjects into it, and you can see our names on it, me, Dr. Nicole, and Needa. So the table of contents. So I will guide you through briefly the reason why this project was done, how it was done, and then basically we look at the outcomes for all our subjects included, and look at a single case study. So, some of these things are really trivial in a way, but I think they're important. So we know that the incidence of non-communicable diseases is really increasing. The quite significant proportion of deaths is really associated with dietary habits. And we know that lifestyle interventions improve stroke and cardiovascular risk by a significant factor. So the effects of interventions may last for more than 12 months, depending on the studies. And we have different nutrition programs that improve incidence of cardiovascular disease and also fatality. I listed a few of them, as Dr. Nicole mentioned. We are not necessarily focused on a particular type of nutritional intervention, but more about the lifestyle intervention. So there were multiple immersion programs published in the literature, and there's evidence saying that plant-based diets and exercise may decrease risk factors and reverse chronic disease. Lifestyle immersion may improve cardiovascular disease, but also microbiome composition. And what is important here is that, different duration of these immersion programs may lead to the same outcome. So even short programs as short as 6 days may cause some tangible changes. So we know also that whole food plant-based diet programs improve lipid profile, inflammatory profile within a short period of immersion. We know also that alternate day fasting can improve insulin, our metabolic health, our body weight and body composition, as well as our cholesterol levels and particle sizes. So there's a lot of research about some additional markers of our risk and also biofeedback. So we know that proteomics was shown to be superior to clinical risk factors in predicting cardiovascular disease. Employing AI tools in proteomic assessments also improve our risk prediction for cancer, dementia, and also death. But of course, these predictions are based on in silico assessments. So SomaLogic is mentioned here because they partner with us in the study. So the company developed proteomics for detection, subtyping, and prognosis of cardiovascular disease, and they are very robustly published in the literature. And we use Welltory as a free solution to monitor heart rate variability in our patients, and it's based on a 1 minute measurement, and it has excellent correlation with the ECG. So the objective of the project was to determine the effects of a short 3-week controlled environment, a lifestyle intervention that employed a whole food plant-based diet, exercise, stress reduction, health education, and the effects of those on cardiometabolic markers of disease, and also proteomic markers and markers of body composition and hepatic steatosis. So the primary question was, what are the effects on markers of the above mentioned and proteomic markers of disease of that intervention? And then what the effects were on the quality of life. So as Dr. Nicole mentioned already, the study was included 12 volunteers with chronic disease. It was an open label project, and the inclusion criteria were quite broad, basically adults above 18 years and coexistent, and the presence of coexistent comorbidities. There was a mention already about the reality TV show, and the study was based on an island, and participants were blinded to the intervention to the very last moment of the initial part of this project. Intervention was conducted by external group, and we mentioned here Cleveland Clinic because at that stage the study was run by Cleveland Clinic Abu Dhabi. So basically, a CCAD team conducted pre and post testing, monitored medications, and ensured safety of the project. So I just wanted to briefly mention the assessments that were conducted. So basically, we looked at total number of lifestyle cardiometabolic medication changes within 21 days of baseline, change in vital parameters, biometrics, laboratory changes, and also changes in proteomics as per SOMA signal risk score at baseline and day 19 and at 3 months, and also looking at improvements of HRV using the previously mentioned Welltory application. So I just wanted to show you what SST, somologic signal tests were used. So basically, there's a few of them. So you see the secondary cardiovascular risk for 4 years. So just a quick comment on soma signal tests. So as we know, these are proteomic-based tests and related to non-communicable diseases risks, and some of them are correlated with biometrics and other measures. So we have the cardiovascular risk, we have liver fat, we have glucose tolerance, we have kidney function, we have alcohol impact, cardiorespiratory fitness correlated with VO2 max, resting energy rate, body fat percentage, visceral fat, and lean body mass. So this is a brief overview of the daily schedule for all of the participants. So after waking up, they would have physical activity for 1 hour, then breakfast for 1 hour, nurse check-in, physician appointment, education sessions that were run by physicians, then lunch, then mindfulness sessions, then dinner, homework, and sleep. So it's important to mention that all of the meals in this project were prepared for the participants, and they were not allowed to consume anything beyond that. So I just want to move to the results section to just show you a depiction of the demographics and metrics. So on the left-hand side here, you can see that we had 5 males, 7 females. The mean age was 49.5, and we had 7 participants, 40 to 50 years, and 5 participants, 50 to 60. We had 25% of our participants were overweight, and 75 of them were obese. 42% had type 2 diabetes, 58% hyperlipidemia, 42% hypertension. And on the right side here, you can again see the some biometrics. So the mean weight of our patient was 112 kilos. The waist circumference mean was 118. BMI on average was 39. Total body fat on average 40.8, and visceral adipose tissue, it was 8 to 6.8. I show you just this little table here of the medications. So basically for that our participants were on. So the rows represent individuals. So you can see that some of these patients were taking quite a few prescription medications, but also you can see some supplements and vitamins here. Okay, so going to the intervention. So as it was mentioned before, it was performed by an external team, which is quite important because these things were sort of beyond our control, and we don't have that much details about the intervention. So it was a 3-week controlled lifestyle-based immersion program, and it's very important to know that all meals were provided to the participants. So the intervention included 100% whole food meals, plant-based foods with minimal sugar, salt, and oil. There was no caloric or quantity restriction though. The participants were receiving daily nutrition education. They had cardiopulmonary exercise, stress management classes, and had physician-led group classes as well. So the intervention is depicted on this graph. So basically the focus was on addressing the mind to change the habits, and it was based on lifestyle, science, and then moving into the life application. So this cycle was the driving force behind this project. All right. So now I would like to show you some of the results. So I start with the soma signal tests. So on these figures here, you will see individual test results. Test results for individual SST groups. You see there's only 6 points on each of these because only 6 patients completed the full 3-month cycle. So we have initial assessment at 3 weeks and then assessment at 3 months. So you can see here for the residual cardiovascular risk, there was no statistically significant difference. For liver fat, there was also no statistical difference over time, but you can see, of course, there were some individual changes, and the trend was basically into the lower liver fat risk. Looking at lean body mass, it's on average it stayed stable. There was no statistical difference here noted. The same was true for the VO2 max. You can see again the individual parameters were changing. For some, the VO2 max SST increased, for some of them dropped. Glucose tolerance again remained in the non-significant spectrum. Body fat percentage was same, non-significant. Again, you can see some individual trajectories here. For the resting energy rate, again, no significant difference in between individuals. Individual trajectories you can appreciate. So again, some increased, some dropped. Visceral fat, same, non-significant, different trajectories. And the last SOMA signal group is kidney function, again, remained non-significant across 3 sets of assessments. So now I will move into direct biochemical and biometric changes in our population. So here you can see weight change. So this is the initial pre-study assessment, TP1, and TP2 as at the end after 3 weeks. So you can see that we achieved significant decrease of body weight. BMI was also statistically significant. So the participants decreased their BMI at the end of the project. For heart rate variability, it did not achieve statistical significance. Interestingly enough, it dropped in the group. Waist circumference, it's decreased in the studied cohort. Looking at body fat percentage, it remained same, no statistical difference. Visceral adipose tissue dropped significantly in the studied group. HbA1c remained stable. Again, the time period of assessment intervention was 3 weeks, so we would not expect for this to change in such a short period of time. However, fasting glucose dropped significantly in all of our in the studied cohorts. So very interesting, high sensitivity CRP. Also, we demonstrated a statistically significant decrease in the studied group. Looking at our cohort's lipid panel, so there was no statistical change in HDL concentration. As far as LDL particle size was concerned, there was a statistical decrease in LDL-P of note. Looking at lipids, insulin resistance score, there was also no statistical difference. So I just listed here on the right-hand side our non-significant results. So there was no significant change in LDL concentration, LDL size, HDL-P, triglyceride levels, total cholesterol, and the others as listed. All right. So I would like to move into a case study now. So this is one of the participants. So the participant information is the following. So it was a 43-year-old male. Medical history is hepatic steatosis, vitamin D deficiency, pre-diabetic, microalbuminuria, hyperlipidemia, essential hypertension, insulin resistance, class 1 obesity, and the subject was on amlodipine, cholecalciferol, hydrochlorothiazide, and cetirizine. So here you can see the change in anthropometrics. You have the pre and post, pre-study and post-study. So you can see that in this particular individual, there was an interesting weight loss, 9 kilos, BMI improved as well, waist circumference improved, heart rate variability dropped down, which is an interesting finding, whether the environment and the intensity of this project affected this particular individual is, of course, a speculation. Total body fat did not change that much, and visceral adipose tissue improved. So looking at this participant lab results, you can see it, different items are listed here on the left side, and you have the pre and post results. So looking at these, you may note that uric acid levels increased in this individual, high sensitivity CRP dropped down, LDLP improved to the upper normal limit, LDL concentration improved, dropped down, triglycerides improved as well, and overall total cholesterol improved, and alkaline phosphatase got better as well. The rest of the numeric parameters, as you can sort of see this on the screen, remained more or less stable. Of note here is ApoB, it's also improved. So looking at the SOMA signal tests for this particular individual, they are nicely depicted here with this colorful graphic. So the secondary cardiovascular risk, you have the pre and post. So basically it's remained low. Liver fat improved from some excessive fat into no excess fat. The cardiorespiratory fitness, VO2 max, changed from 27.1 into 27.8, so still remained in the low side of that spectrum. Kidney function improved in the post phase. Body fat percentage improved as well, from the sort of average to more interfaced to less an average. Visceral fat improved significantly from high to low, and lean body mass remained more or less stable. And again, this is somalogic. These are not direct measures, so these are proteomics. So the short-term outcomes for this particular individual were that this person had significant improvement of metabolic and biometric parameters. They discontinued their medications. So I think this is a very significant improvement. But there were no major changes in the somalogic, proteomics, and long-term risk in this participant. So I would like to conclude here about our immersion project and say that short-term comprehensive health immersion program is feasible and can lead to really tangible laboratory and biometric changes. Though we have not observed any significant changes in proteomics, and we suggest that data collection for health immersion programs is important, and maybe it would be useful to establish a global data repository allowing for other groups to contribute with their results and having more numbers really to look on the effects of real life lifestyle immersion programs. So I would like to pause here and open the floor for discussion. Thank you very much for your attention.
Super. Has anybody a question?
Hello, everyone. Thank you, Dr. Piechowski, for the great presentation. My name is Dariusz Sołdacki. I'm a Scientific Director of Longevity Center Europe, clinical immunologist, internal medicine specialist. as a background. Really interesting study. For me, it's really important that it's only 3 weeks, and it's really hard to motivate our clients, our patients, to motivate them for changes for longer period. This and this was really controlled 3 weeks. Yeah. From our observation, there's plant-based diet. It's really hard to hold the muscle mass, because BMI and body weight is going down, but because of the muscle loss in our observation. And you showed before this somnologic, what's the name of this systems? Somologic. So in somologic, you showed in proteomics that the visceral fat is changed and total body fat is changed, but previously you showed that no changes in the fat and no changes in visceral fat, and body mass goes down. So we can suspect that it's muscle mass, and the metabolic changes are not in good way. It's one comment. And creatinine level, if you lose your muscles, creatinine level goes down, and then the kidney function is better, because creatine comes from muscles. So if you lose muscles, then you have better creatinine and theoretically better kidney function, which is not true. Yeah, so it's my comments as a clinicians and observing, but yeah, motivation is a problem, because they have food from your project and still not so good improvement. Yeah, but interesting.
Yes.
Thank you.
Yeah, so Dr. Dariusz, thanks so much for this comment. And as we said from the beginning, the food intervention is part of the, I would say, bullet that we dealt with. So I don't want to sort of dive into details which nutrition program will be better. I agree with you that this short period of time, 3 weeks, gave amazing results. And this is very, I think, stimulating for us as healthcare practitioners, what we can achieve potentially with our patients within or outside an immersion program. And speaking about proteomics, yes, so there was no lab changes, but there were proteomic changes. So, of course, the epigenetic part may predict some longer term improvements or deteriorations depending on the maintenance of the lifestyle intervention. Yes, so I think this cohort showed us that in a short immersion program, the use of proteomics may not necessarily be useful because we don't see any immediate change, which is not expected, of course. But then if you consider cost of proteomics and what other parameters we can get directly from patients, so labs and biometrics, this may be more reassuring and both for the clinician and the patient. And I fully agree with your comment about plant-based diets in the context of muscle mass and sort of creatinine ratio and all of this. So yeah, thank you for your comment.
You report that you did no calorie restriction in this diet. No calorie restriction.
No calorie restriction.
No.
Okay.
And protein restriction was in the plant-based diet or sustained?
No, it was sustained. There was no restriction in that aspect. Yeah.
Very much.
Thank you.
Thanks so much. We have a question from Katarina. Yes, exactly. Go ahead.
No, I think she cannot talk. So why the attrition that you only had 8 or 6 or a lower number of individuals in the end? Were everybody so depressed and psychiatric because of the plant-based food? Maybe you can comment also on the psychology in this story.
So thanks, Andrea. So it's a good comment. So I mean, as you saw, the HRV dropped in the participants, I think, to some extent. So this may be in part the answer, whether they were stressed with the intensity. Of course, it's a speculation at this stage. So all of them completed the study, but for the follow-up third sample of somalogic, we just had we had it for only the six participants. But all of the the biochemical and biometric parameters when they're leaving the camp, these were available. So, but again, from the feasibility perspective, all of the setup for this project, and again, even if you add the layer of reality TV to that, is of course nothing that we can reproduce in real life for obvious reasons. Then question is really a pragmatic question. Are people happy to be contained for a defined period of time and had the intensity put on them? And then whether this is sustainable longer term, or what outcomes they'll have, like in a year's time, 2 years' time, if things don't continue. So I think it's a very nice immediate snapshot, but I don't think it gives us enough fuel to sort of think what the long-term consequences would be. I think it would be very interesting to see whether their lifestyle aspects change, whether their lab results changed, and the biometrics, and whether they are on meds or off meds and everything else. So question is, would this stay in them for longer? Yes, that's I think for me as a practicing clinician, a very important question that I don't have an answer to at this moment.
Also, if I may please just add like a comment around what Dr. Bart already said. So looking at these, 12 participants and their histories, they all had very complex thing going on in their life, so obviously 3 weeks of intervention would not be enough to, change a whole mindset. It was definitely a good start, but we also have to take into account the other aspects that were going on in their life, which were like, stressful, that you obviously can't talk about. But I believe that also must have contributed to kind of sustaining their follow-up beyond the program. Do we have another question?
No, not yet. Just if you have a question, just raise your hand or speak up. That's all good, or type it in. May I ask you if you did psychological testing on these individuals? Of course, very often these kind of changes, but there was a reality TV, so I think that's already a change in psychology. But were people grieving for more meat, and now they had to be vegetable lovers? Do you have any psychology here?
Yeah, so thank you. It's a very important question. So you may imagine, and we know from other reality shows, how participants, they are chatting in the corridor. So how bad the program is, how to escape, and how to cheat and things. Yes. So I showed this little graph of the intervention when there was this mind focus. So basically, the participants were infused with the notion that you are what you think. There was a focus on developing new mindset and overcoming emotional eating and addictive food relation. So though, as we said here, we were not part of the exact intervention, but I can tell that there was a focus on sort of the psychological aspect of that and coaching for the patients, but I don't have the exact details. But again, this is a very good and valid point that you raised. Thank you.
Any other questions?
I may have a quick reflection as we speak and wait maybe for the others to ask a question. So I was really amazed to see the results of the Soma signal tests. I mean, of course, we don't expect things to change that quickly. Proteomics, there's some dynamics behind that. And yes, so basically I thought we would see more of that. Maybe longer duration of the program would then have more profound and multi-layered effects on the proteomics, because we have several thousands of proteins that are assessed in all of these subgroups. So I still think that proteomics is a very valid tool. Question is whether this is for clinical use in practice, and again, what is the duration of the intervention and the intensity of that really to reflect real life. Because in real life, I think we get to the stage of getting chronic disease by daily, maybe not so intense, unfortunate changes to what we do. And then it has a profound effect on us. So I think in that context, having a longer, maybe less intense intervention, which again goes back to what we do clinically. As we see patients for follow-ups and they get better, hopefully, as we see them. And then we may observe some proteomic changes behind the scenes.
Yeah. Katerina, you are raising your hand? You raised your hand? No.
Yeah, yes, I did. I just wanted to ask the group who else had some experience with SomaLogic. And actually, you show nice results, some changes in the profile that were, like, for example, I remember the change in fat and all that. And even though you did not see that on the measurement of fat, is not probably expected in such a short period of time, but the profile of proteomics may predict how these people will respond. Did anyone else here is working with SomaLogic? And I just want to ask the group if they use the SomaLogic in their practice or research.
Can I just make a comment? I'm not using it myself. This is Richard Barker, but I listened to a very interesting presentation from Dr. O, I think, O-H, from Stanford, who has done some quite systematic work using proteomics, including SomaLogic, on the results in terms of markers of healthy or unhealthy aging. So it's slightly disappointing to see these results being so minimal, but I take the point about the shortness of the study.
Maybe I can start. We don't use it in clinical practice yet. We are doing it in research and need hundreds and thousands to get a significant result. So huge effect size. It works on populations, but not yet on individuals. So we didn't implement it in clinical practice. But this is just where we are. There are a couple of metabolites, proteins, out of the population studies, which might be interesting to study. I'm at the Gordon conference in Barcelona about systems biology, so we are talking the entire day about omics. So I just heard a publication of a presentation where really from the 5,000 proteins, they selected the 20 there associated with the incidence of age-related diseases, and I think that's what we want. And now we have to validate that if we can actually get them. So I think it's really narrowing down to the ones who really make sense, also from a methodology and perspective, and then trying to implement it without variation of the methodology, how to measure it, because that's even a bigger problematic thing, the reproducibility.
Also on that note, so sorry, just a quick comment. So when I was looking into like the SomaLogic database and where they get most of their information from, so they primarily do studies on UK and US populations. So is this something to be mindful of if you're looking at like other ethnic groups and how that would relate, basically?
Anybody of you already include in clinical practice either metabolomics, proteomics, or lipidomics approach? We have tests already, and especially True Diagnostics is going from epigenetics, including proteomics. Now, is anybody already at that step to jump into the water of omics in clinical practice and making use of it? I see silence as no. That's good. Yeah.
So
go ahead.
Yeah, we are working on our program here at Mayo in Arizona, and I'm exploring some of these omics for not so much clinical practice, but probably some research. And talking about research, I just want to ask the group, I'm thinking about the N-of-1 clinical trial use in longevity medicine. I don't know if you're familiar with this concept, probably you are. I think this is an opportunity for us to look into this modality of N-of-1 clinical trial and how to apply. And I think it's important because we need to learn more and more. Even now we have one patient. If we can do interventions. And of course, it's not easy because what type of intervention are suitable for N01 clinical trial, you know? So it's a new field, but I am looking into that because I don't want to, I mean, there are some, you know, belonging to an academic center, you cannot really apply in your care or kind of experimental treatments. It's not easy, you know, you have a practice approval and so forth, but N01 clinical trials opened the door for applying FDA-approved treatments out of label based on preliminary data to apply. So I just want to ask if any of you are doing N01 clinical trials or thinking about that?
Anybody? So we are doing it in research. We are doing it at N01 to titrate NMN based on NED levels to actually see if we can titrate, as everybody in clinical practice would titrate insulin for changing glucose levels. So we are doing that in NS1 for NMN and NED. And I think the entire NS1 approach is Maria, can you mute Ronald? I think the NS1 approach is a quite nice one if you know what you want to do. We can do that with exercise. You want to establish a certain VO2 max. Okay, how much endurance, how much strength, how much do you need? And by titrating that by always measuring again the outcomes you have in mind. I think that's NS1 sounds very interesting, sexy, and very intelligent, but I think we very often do that in clinical practice. Does anybody else? Does titration already for interventions can be lifestyle? It can be, I think we do that, but supplements or medication. No? Not yet. Yeah.
I will let you know I will let you know in a couple of months next year, hopefully, to see how this works, because I want this to apply as much as I can to the patients who are coming in the clinic, because you can do randomization with these patients indeed, and double blind intervention if you are using a supplement. The question is, what type of measurements you have to use to capture that when you have, a complex, still explore field of longevity. So that will be a challenge. But I'm thinking about several scenarios, so I can use supplements or medication in a double blinded crossover design with one patient. That it's what N of 1 clinical trials is. So we'll see how that works. Thanks.
Good luck with that.
I think the problem is because, of course, we can supplement something like NAD, and we can monitor now NAD plus from the fresh blood or dry blood spot. In Longevity Center, we are testing now the NADH autofluorescence equipment for assessing the microvasculature. But I think it's the beginning of the studies, and it's not easy to supplement anything if we have no idea what the microcirculation is in the tissues and how it goes to the tissue and works on the mitochondrial level. So we need still development in this field and more equipment to monitor the treatment, because supplementation of NAD, we know from fresh publication that too much NAD is cardiovascular risk and death risk. So supplementation is not so safe as we thought before.
Yeah. But plant-based food is safe. So let's finish a
Yeah,
little
but
bit positive.
uric acid went up. Uric acid went up.
Yes. So don't do it with gout. Yes. Okay. Okay.
Do you have any suggestions if plant-based, because it's really anti-inflammatory diet, but how to supplement effectively the proteins? Because fish and theoretically Mediterranean diet, I saw the comment here, but when we try to switch someone to the plant-based diet and then additionally seafoods and fish, the mercury level is 4 times the normal range. So it's really hard. Legumes, a lot of bloating, so it's unpleasant, and probably HRV levels go really down if you stressful situation with bloated belly all day. So do you have any suggestions how we can use the protein intake in the plant-based anti-inflammatory diet? Do you have fresh ideas?
So if I can chime in here quickly. So, well, I may argue that plant-based diet it's really anti-inflammatory diet. This is my sort of a separate view on that, because you mentioned bloating. So I think the nutrition programs needs to be tailored really to the individual. I think our projects show that having very likely ultra-processed food and standard American diet to start with, and then any nutritional intervention and lifestyle intervention in a controlled environment worked for the short-term outcomes. That's for sure. So we can't say what would this be if the other group had like paleo diet or vegan diet, whatever. Yeah. So this is a speculation. I strongly believe that there's an umbrella nutrition for individuals, because you have someone with cardiovascular risk and they have significant IBS component and autoimmunity. You may argue whether high sort of plant-based nutrition with leafy veggies, with people who have FODMAPs, for example, is the way to go. But again, this is tailored. Yes.
Everything personalized in longevity. We agree with you, of course, but the suggestions like here, Carlos, soya protein. For me, as a clinical immunologist, soya, it's phytoestrogens, estrogens, and hormonal disbalance change the LH and activity of macrophages, and yeah, so it's not easy to fulfill by soya only, yeah. And this is I'm also allergologist, so it's one of the main allergen in the food intolerance. So soya, yeah. So it's not so easy. It's not so easy to tailor-made diet, but it's base.
I mean, also to add to that, like, there are some great sources of plant protein, including like legumes and lentils, which are like not only healthy, but also great. And coming to the topic of bloating, I think that primarily comes from increased fiber intake. And what we see is like, the recommendations of going from 25, 30, 40 grams of fiber is there has to be a gradual increase. So if you're following a standard, as Dr. Bart mentioned, American diet, where the fiber intake is generally in most cases below under 20 grams per day, and you just shift suddenly like next week to about like 35, 40 grams of fiber, you'll definitely have problems. So a gradual increase, that comes within the personalized approach, where there's a gradual shift as opposed to just like completely changing to 180 degrees. Yeah, so that's just my opinion on that.
Yeah, I agree. Slower changes, but even in my case, when I tried a total vegetable plant-based diet, in body mass over 90 kilogram and 85 kilograms of muscles, my muscles shrink really severely on the plant-based, even without bloating and with legumes. No, I cannot sustain the body mass, muscle body mass. Yeah, so it's really hard to of course.
Out of curiosity, how much grams were you getting for protein? Were you like getting at least a gram per kg? Protein.
I don't remember previously, but when our nutritionist consult my diet and increase a little protein, then I noticed really big improvement. So it was, but without fish, I cannot do that before. We tried and impossible for me. So it's my private observation.
If somebody would like to have the next session about proteins, that would be great. There's lots of discussion. And I think it's quality, but it's also ingredients which should not be in supplements or in food. Yeah, toxicities.
Yes.
We are reaching the end of this meeting. Is there any more precious question or comment next to thinking Bart and Needa.
I just wanted to say thank you very much for hosting us. It's a great pleasure to meet the team and sort of be part of the group discussion and everything else. I'm really looking forward for the next meetings. Thanks so much. Thank you.
Likewise. Thank you.
Perfect. Thank you so much, everyone.
Thank you.
You. Goodbye.
Bye.